Dr. Beth Lalonde got her medical degree at the Medical College of Wisconsin, where she also completed a residency in internal medicine, as well as a fellowship in endocrinology. Dr. Lalonde is board certified in endocrinology by the American Board of Internal Medicine. And Dr. Lalonde has been seeing patients here at St. Agnes since 2013.
Yeah.
So help me welcome Dr. Lalonde. Thank you.
All right. Can you all hear me on the microphone? Yes?
Yes.
All right. Thank you for the invitation and for coming today. I was asked to do this, I think, sometime in the spring when Patty had contacted me, and I got Dr. Finley to switch schedules so it could be a day when I'm up here for clinic and come do the talk. And then I'm getting asked by Nicole to give the slides to her. I'm like, oh my God, this has really come up with me quickly. And I've never done a thyroid disease talk. I've been in practice for 20 years. And I obviously practice general endocrinology. I have a thyroid ultrasound clinic on Monday mornings at my main office in North Hills, Menominee Falls, and do ultrasounds and biopsies, manage a lot of thyroid patients. So thyroid disease is a huge part of my practice, but I've never been asked to give a talk on thyroid disease before. And they really just gave me that topic, thyroid disease. So I decided for primary care, I'll cover a little bit of a lot of things. So I want to talk a little bit of thyroid nodules and some of the new things like TIRADS and how we classify nodules with respect to risk for malignancy, the use of molecular markers, which may or may not be familiar to all of you. And then we'll talk a little about the diagnosis and treatment of hyperthyroidism and also hypothyroidism, both subclinical disease. I'd like to touch on combination T4, T3 therapy, and if there's time, we'll talk a little bit about thyroid hormone and pregnancy. So with that, my personal approach to thyroid nodules, when I see a patient with thyroid nodules, whether it's a multinodular goiter, whether we feel the nodule on exam or it's an incidental finding on imaging, I always ask myself 3 questions. And the first one, is this nodule have autonomy? Is it making too much thyroid hormone? And then the second question is obstructive symptoms or compressive symptoms. And the third question is this nodule, or what is the risk for malignancy? So with respect to hyperfunction, you need the TSH, and that's really the first approach. Is there a TSH? And it's always nice when I refer to patients to evaluate thyroid nodules when they already come with a TSH. Then the next question about obstructive symptoms would be hoarseness, difficulty swallowing. By far the most common symptom people have is globus, just this feeling of a lump or something in their throat. And then symptoms like dyspnea are much more concerning. With respect to malignancy, we always ask about a prior history of head and neck radiation, which certainly increases the risk for malignancy, and if there's a family history of thyroid cancer or thyroid cancer syndromes like multiple endocrine neoplasia. And then the question always is, does this nodule need to be biopsied? And now we've added in what is TIRADS. So thyroid nodules are very common, and everybody in practice here knows that. Probably a good 2/3 of people have a nodule on their thyroid on routine ultrasound imaging. And most of these nodules clearly are benign and very low likelihood of cancer. And a lot of the small nodules that either are malignant, most of them are not any major threat, non-aggressive behavior, and are not going to cause the patient to die. And as we have recognized more and more nodules as we do more imaging, there's more biopsies and more surgery, yet the mortality for thyroid cancer really isn't increasing. So the concern is, are we over-biopsying and are we over-evaluating little thyroid nodules, and is this really necessary? And so we're now trying to step away and not over-evaluate little dinky nodules and focus on the ones that are a bigger threat. And from that has this development of this concept of TIRADS. So everybody in private practice knows TIRADS, and this is out of the American College of Radiology, and it's thyroid imaging, radiology, and data systems is what that stands for. But you're essentially looking at these 5 different features from thyroid ultrasound: the composition of the nodule, the echogenicity, the shape, the margins, and then the presence or absence of echogenic foci. So when our radiologists read the ultrasounds, we're asking them and hoping that they're going to give us this information. But from each of these categories, points are assigned, and then you add up all these points to help sort out, is this nodule more or less suspicious and does it need to be biopsied or not? So a pure cyst is not a thyroid cancer. We don't worry about biopsying a simple pure cyst. Spongiform nodule is usually a very benign nodule. The more solid a nodule is, the more concerning. Echogenicity, a pure cyst doesn't have echo. A very hypoechoic nodule is more suspicious for cancer. And then the shape has to do with, in the transverse plane, the depth from anterior to posterior, that's the height, versus the width, and taller than wider is more concerning than the opposite. The margins, a nice smooth margin on ultrasound is reassuring. A nodule that's invading into the outside of the thyroid is very concerning. And then the presence or absence of microcalcifications, even coarse calcifications, add to the risk. So again, we look at these different features. You get you have to select one thing from each of the first 4 categories, and then on the echogenic foci, each of these little subcategories, you get points for each one. And then you add that all up, and it will give you the TIRADS points. So benign nodule will be 0 points, TIRADS category 1. Benign, you don't have to do a biopsy. Up on the other end, a nodule that has 7 points or more, that's a TIRADS 5. That's a very highly suspicious nodule. You're going to biopsy at a size of 1 centimeter or more. Now that might change if you've got a patient that's had prior cancer, thyroid cancer, if you have a patient that has a known genetic mutation or they come from a family with lots of papillary cancers, we might biopsy something smaller. So it's not all comers, but it gives us an approach so that we're not over-biopsying little things that are less likely to be concerning or malignant, or if they are malignant, they can be followed. We've implemented this, I think, about a year ago at the medical college, where the ultrasound reports always have the TIRADS listed in all the nodules, and I'm seeing it increasing in other centers. The concern is the transparency to patients, that they get these reports, and they have a really difficult time when they read TIRADS 3, mildly suspicious, or TIRADS 4, moderately suspicious, and then we're not biopsying. It has a 1.2 centimeter nodule, it's not big enough to recommend biopsy, and they have a really hard time understanding why we're being negligent and not pushing to pursue it. So the next rendition of this, I think they're going to take that off, those labels off, and then we're the ones that are going to have to figure out, what to do with each one and in terms of the biopsy and whatnot. This is just a little example. Get this out. So these are microcalcifications within a nodule. So this is the transverse view of the left lobe of the thyroid. This is the trachea. This is the carotid artery. And this is the left lobe, and within it is this nodule, and you can see all these little white hyperechoic foci that are microcalcifications. This is a benign feature, so this nodule, again, this is the trachea here, and the isthmus of the thyroid across, and this nodule here is very cystic looking, and then there's this little white bright dot in the middle of it, and you see here this shadow that kind of comes behind it. And that's what we call a comet tail artifact, and that's a very benign feature that we often see in colloid cysts. So it's sometimes difficult for people to, especially in static pictures, to differentiate a calcification from a comet tail artifact that's benign. And when we go and look at some of these reports, like how do they come up with this? This doesn't look all that suspicious live, and how do they determine these points to be worried about something? So even though these categories sound really objective, there's a lot of subjectivity, depending on the ultrasonographer and how they interpret some of these findings. So it's easy to see things changing and they're interpreted differently. Okay. All right, and this is another nodule within the thyroid, and then this extension into the soft tissue outside of the thyroid. Very concerning feature. And this one has more of this lobulated contour, also more suspicious. More external extension. So once we do a biopsy, a thyroid fine needle aspiration, we're waiting for the pathologist to give us a report. And the first question, is there adequate cellularity on those slides to say this is diagnostic? And they need so many clusters of follicular cells to be able to say that. If there's not enough cells, it's category 1, Bethesda category 1 or non-diagnostic, and we need to go back and give them more information. If it's category 2, it's benign, and that we have a very low likelihood that this is a cancer and we can not pursue surgery. If it's 5, it's suspicious for malignancy. If it's 6, it's malignant, they're going to surgery. If it's 3 or 4, they're indeterminate. And that's the part which we all detect. Hate getting those reports, indeterminate, because now what are we going to do? So class 3 is atypia. It's about a 10 to 30% risk that that nodule is malignant. Most of the time it's not. If it's a follicular neoplasm, class 4, it's about a 25 to 40% chance of malignancy, depending on your center, but you don't know. So when you get a 3 or a 4, historically those patients went to surgery, and most of those patients really didn't need to have their thyroid taken out, but to get resolution and an answer that it's cancer or not, they had surgery. So now we have introduced the concept of molecular markers, and they do, I think I was told they use a Afirma, if anybody can verify that, Afirma here. I use Afirma at the medical college, I also use Thyroid. But what happens is when we do the biopsy, with Afirma we'll take if you do it as an Afirma, we'll take 2 passes that are sent for cytology. Then we'll take an additional 2 passes that go in a special tube. If the pathologist reads the nodule as an indeterminate lesion, they'll then open up the other tube and run these genetic markers and genetic analysis, and will further qualify whether this is malignant or not. The Thyroid allows us to take an old slide, and they can scrape the cells off the slide and do the genetic markers on the prior biopsy. You don't have to necessarily have a fresh sample, and that's nice. The Afirma, you have to get it packaged up. It goes on ice overnight, and then the other ones are at room temperature, a little more stable. But prior to this, a lot of patients with indeterminate cytology underwent surgery, and this is a way to not send a lot of people to surgery that we don't really need. Some of these will do specific mutational analyses, so like BRAF and RAS are genes that are associated with a high risk for cancer. Afirma takes like 167 different genes, and they run it. Don't ask me how this really happens, but they look for all these things, and then if there's a lot of these that are abnormal, they will read it, and the fax comes back, and it's either green or it's red. Red is bad, highly suspicious with an indeterminate cytology. They're going to surgery. About 40% of it, they have about a 40% risk that it really is cancer. If it comes back green and the classifier is red as low suspicion with an indeterminate nodule, you're at 98%-ish, again depending on the source, that it's benign. So we'll watch those patients and not send them to surgery. So it really has changed how many people are going to have surgery. So I kind of woven a couple cases into this talk to illustrate a few points, and I always think it's more fun to talk about patients anyway. But this is a 56-year-old woman that I saw in my practice about a month ago. She was self-referred to evaluate a thyroid nodule. And her story is she had come in with left-sided neck pain and a very tender lymph node. She had seen her primary care physician. They'd done a neck CT scan, and the left neck looked fine, but incidentally, there was a nodule in the right lobe of her thyroid gland. Well, she'd had a lot of upper respiratory infections over this last year. She was complaining of exertional sweating for several years, weight gain, cold intolerance, and fatigue. She never had head or neck radiation. There was no family history of thyroid cancer. She'd underwent a surgical menopause at age 45, had taken estrogen until age 50. She had GERD, and her only medicines were calcium, multivitamin, and vitamin D. On exam, she did have a palpable thyroid nodule in the right lobe, no lymphadenopathy. And here's her ultrasound. So this is the transverse view in the right lobe of her thyroid, the carotid artery. This is her trachea, and this nodule is replacing a good part of her right lobe. And this is the longitudinal, so from her head to her toe, the other view. So it was about 2.7 centimeters in its greatest dimension. It's solid, it's hypoechoic, it has smooth margins, and then these little white dots, they read as microcalcifications, and when you add up 4 plus 3, you get 7, and it's a TIRADS 5, a highly suspicious nodule. So again, we go down all these points, TIRADS 5, highly suspicious, should be biopsied if it's over a centimeter in size. So she said to an ear, nose, and throat physician, And he talks to her that she needs to have her thyroid removed, and then you're going to be seen by endocrinology. They're going to give you radioactive iodine for your cancer. But before we send you to surgery, we're going to do a biopsy. The biopsy's done, it comes back benign, Bethesda category 2, so he tells her, we'll see you in 6 months, you don't have cancer, you don't need surgery. Well, she's still bothered by this, you know, from I need surgery to, and I have cancer, to now I don't have cancer, and I still have this lump and wanted another opinion. So my question to you is, what objective information of those 3 things, when you have a nodule, what point 1, 2, 3, what have they not done yet? What do you not know yet? Autonomy, symptoms, malignancy. We know malignancy sounds low on the list because the biopsies happen. We don't think her symptoms that she's talking about so far are related to the nodule, but I don't know what her thyroid function is, and I haven't shared that with you. So that's the next thing. What's the function? Is she hyperthyroid or is she euthyroid? So she had moved to Wisconsin from Georgia. And I went back and got her thyroid function test going back to Georgia, and it was, 12 years ago, her TSH was 0.5, and then 0.4, 0.38, 0.258, 0.143, so every year it's getting a little lower. She moves to Wisconsin, and we lose a few years before she gets established with a new doctor. TSH is suppressed at 0.03. Free T4 is low normal. And he tells her that it's abnormal, but your thyroid's going to burn out, you don't have to worry. I still don't know what that meant, but that's what he told her. So in 16 is a little lower, and TSH stays suppressed. And she actually had one with the same numbers, but this was not connected at all to the problem with the nodule. These are like unrelated things. So this is when I saw her October 25th. Her TSH is suppressed, her free T4 is normal, and her free T3 is on the higher end of normal. So what did I do? I sent her for an uptake and scan. So the question is, why is she hyperthyroid? Does this nodule have autonomy? Is it hyperfunctioning? And I think she's had this nodule for a long time, and I think it's progressively getting more hyperfunctional. So the right test, I think, was to do the uptake. And normally, if the whole thyroid lit up, it would look like a butterfly, and all you see is the nodule lighting up. The rest of the gland is suppressed. There's no iodine uptake. So she has a toxic nodule or a thyroid nodule with autonomous function. So then the question is, do we treat her? She's got symptoms of weight gain and cold intolerance, fatigue. She was talking about exertional sweating, but it wasn't really symptomatic too much for the hyperthyroidism. Our options for treating a toxic nodule would be definitive therapy of radioactive iodine. The iodine's going to be taking up that nodule and melt it, and will restore a euthyroid state. She might even get hypothyroid. You could do a thyroid lobectomy and get rid of the nodule definitively and the source of the extra thyroid hormone with the hope that the rest of the gland will wake up and make her euthyroid. Or you can put her on methimazole or antithyroid medication, but she'll be on that forever because this isn't going to go away. She won't go in remission from that. So do we need to treat her at all? And I actually advised her to choose between radioactive iodine and surgery, and she's elected to have a lobectomy, and that's going to happen before the end of the year. But what is the implication of subclinical thyroid disease or subclinical hyperthyroidism in this case? So when we say subclinical, it has nothing to do with the symptoms. It is a biochemical picture when we say subclinical. So it's a TSH that's low with a free T4 that's normal. If the TSH is low and the free T4 is normal, we say subclinical hyperthyroidism. And then on the other end of the spectrum, if the free T4 is normal and the TSH is high, we say subclinical hypothyroidism. Again, some patients have symptoms, but the diagnosis has nothing to do with that. It's the biochemistry. So why treat her? So this is information from Framingham. With respect to the risk of atrial fibrillation. And when they went back and looked at patients with TSHs that were suppressed at less than 0.1, the relative risk for AFib was about threefold. TSHs 0.1 to 0.4, about 1.6. And if you exclude the patients that were on thyroid hormone with iatrogenic hyperthyroidism, that risk is even higher. This is from the cardiovascular health study. Again, In red, the TSH is less than 0.1, relative risk of atrial fibrillation over a 12-year period is significantly higher than in the euthyroid patients, and then the ones with the TSHs between 0.1 and 0.4, shown in blue, are in between. So the extra thyroid hormone certainly increases the risk for atrial fibrillation. And then this is a meta-analysis that was published a few years ago of 5 different studies, over 800 patients. Overall adjusted hazard ratio was 1.7. Again, higher 2.3 with TSHs less than 0.1, and 1.7 with TSHs under 0.4. I like to say subclinical hyperthyroidism is also a little bit bad for the bone. So, and when they look at fracture risk in subclinical hyperthyroidism, patients that have subclinical hyperthyroidism have higher risk for fracture. So if this is TSHs in the bottom, the less than 0.1, 0.1 to 0.4, a little more in the intermediate risk, but still significant. And it's also bad for the brain. Subclinical hyperthyroidism is associated with dementia, and in meta-analyses, again, overall, higher risk for cognitive dysfunction and dementia in patients with subclinical hyperthyroidism. So I would argue this is important. And based on the observational data with TSHs less than 0.45, increased risk of AFib, dementia, and hip fracture, that you would certainly consider treating patients that have subclinical hyperthyroidism. Now, there's no randomized controlled trial data to guide our treatment. It's all very anecdotal. But in order to prevent adverse outcomes and manage coexisting conditions such as AFib, we would consider treating. The American Thyroid Association, I think most medical, the people that write the guidelines that affect our practice, would argue that when the TSH is less than 0.1, irrespective of how high or low the free T4 is, we should treat. And I see this all the time where because the free T4 isn't overtly high or the patient's not complaining, they don't always get treated. And it's interesting sometimes, especially with these medical records electronically, that you can look back for years and see, how amazingly well somebody's done. But then I also see these little 85-year-olds that have paroxysmal atrial fibrillation, their TSH has been 0.2, 0.3, and you get them back to 2, and their heart problems stop, and they feel a lot better. So I do think it's worth, especially when somebody is older, especially if they're symptomatic, that you're going to think about treating even under 0.45, but especially as they get lower, as they get older, think about treating even at a higher number. Okay, so now we'll get to a little more severe hyperthyroidism. This is a patient, interesting, I saw him back in follow-up here today. I first met him a few years ago. At that time he was 67, and he was referred by his primary care physician to evaluate hyperthyroidism. He had presented spring of 14 with BPH symptoms and was diagnosed with bladder cancer. He underwent resection and then was placed on finasteride and tamsulosin. He had noticed a decrease in his weight and muscle weakness and fatigue somewhere starting around summer of 14 when he started these new medications. So he attributed his symptoms to these new medicines for the prostate. He also had developed pressure behind his right eye, double vision, and a decrease in his ability to focus. And he went in to see the eye doctor. They thought he had a cranial nerve palsy to 4-3 and ordered an MRI of his brain. And that showed this thickening and enhancement of the extraocular muscles of his orbits, both sides, with the right much worse, and proptosis of the globes of his eye, all consistent with Graves' eye disease. So then, given that information, the primary care physician obtains thyroid tests, and his TSH was suppressed. His free T4 is about 3 to 4 times the upper end of normal. His free T3 also elevated. So this is now January 15, about 7 months from the onset of all of his symptoms. And he was placed on PTU, 50 milligrams 3 times a day, and a referral was sent to endocrinology. So when I met him about 2 to 3 weeks later, he reported weight loss and fatigue, but he denied a lot of other hyperthyroid symptoms. His eyes were the most significant problem. He had tape over the lower part of his right lens because he couldn't get his eye up, and he had such terrible double vision. He was trying to not even see out of the right eye. He was streaming with tears. His eyes were so bloodshot and clear proptosis. He was complaining of the photosensitivity and irritation and more redness and pressure. His family history was negative for thyroid disease, but his brother's mother and maternal aunts had rheumatoid arthritis. He's a retired man, non-smoker, but had an interesting hobby as a beekeeper. He was hypertensive, a little tachycardic, very lean, weighed 135 pounds at 65 inches, and he had this dramatic proptosis and the eye findings I just described. On confrontation, he could not get his eye up and out, which is the most common defect with Graves' eye disease, that they cannot look up and out. He couldn't get up, he couldn't get out, he couldn't get up and out. He was just downward looking. And his thyroid wasn't really enlarged, but very firm, and he had a clear tremor with outstretched hands, brisk reflexes, no bruit over the thyroid. Frequently in Graves' disease, the increased vascular age of the thyroid, well, you'll hear a bruit over the gland. So the big question at hand was this Graves' disease, is it thyroiditis, is it a toxic nodule, or a toxic multinodular goiter? And those are the three things that you usually are thinking about when somebody comes in with hyperthyroidism. Is it autoimmune thyroid disease, an inflammatory transient process, or a nodular problem? Or are they on thyroid hormone and you're giving them too much? That's always, or are they surreptitiously taking it? But those are the main things you're thinking about. And ordinarily, we would do a thyroid-stimulating immunoglobulin or an uptake and scan to sort it out. In his case, he had clear Graves' disease with the eye findings, and there was no question that that's what he had. So I advised a switch from the PTU to the methimazole, and I went through the different side effects, and I think it's really important to review the side effects of these drugs with patients so they know what to be looking for. I sent him to the Eye Institute at the Medical College to get enrolled in a special thyroid eye disease study that was being done at the time. They were recruiting patients that were in the active phase of Graves' eye disease. And I got the thyroid stimulant immunoglobulins, which were very elevated at 431%. I told him to avoid smoke, which was important in his case because beekeepers use smokers to keep the bees away. I have learned so much about fishing and hunting and bees coming up to Fond du Lac that I never thought I would learn about. So when you see patients with Graves' disease, you really have a choice. And the three main, always you have a choice of doing nothing, which is usually not a good choice. But I always present that as an option, and then the risks of not doing anything. Anti-thyroid drugs, radioactive iodine ablation, or surgery. If you choose iodine or surgery, you're going to cause them to be hypothyroid. It's definitive treatment, and they're forever after going to be hypothyroid. If you choose the drugs, you have the reversibility. Most patients don't become hypothyroid, but it's not definitive. There's side effects of the drugs, and you need to clearly follow them and assess for compliance. It's not as expensive, but you have to have a compliant patient to come back. We do worry about the radioactive iodine worsening their eye disease, and surgery is certainly more expensive, and there's risks of recurrent laryngeal nerve injury and chronic problems with their voice, and the risk of hypoparathyroidism, so it's not without risk. Historically, the American, and this is a poll of physicians that are members of the American Thyroid Association, so thyroid experts. I'm not in the ATA for what that's worth, but looking at data from 1990, the majority of the physicians had advised radioactive iodine as the treatment for Graves' disease, and only a third had advocated for anti-thyroid drugs. Moving forward 20 years, that was increasing in popularity to choose anti-thyroid drugs, and radioactive iodine was falling in favor. And then this is data from about the last decade with physicians in the United States and how they treat Graves' disease. And this is all comers, and they are showing that anti-thyroid drugs are growing again in popularity, and there's a reduction in how much radioactive iodine is being administered to patients with Graves' disease. So the current American Thyroid Association guidelines recommend methimazole in virtually every patient who chooses anti-thyroid drug therapy for Graves' disease, except during the first trimester of pregnancy when we prefer PTU. In the patients with thyroid storm, which is very rare, and in patients that have had minor reactions to methimazole who really don't want to commit to surgery or radioactive iodine, and they want to stay with anti-thyroid drugs, we'll switch them to PTU as well. Methimazole has a lower risk for hepatocellular toxicity, and that's why it's favored. and then the PTU for the first trimester because of a scalp defect that can happen in the babies in utero in the first trimester, and then we flip it back second trimester the rest of the pregnancy. You can use antithyroid drugs during pregnancy. The patients need to be informed of the side effects of the medications, the necessity of letting us know right away if they're having any side effects. I go through all these things with them, but I would usually tell people aches and pains that are different, fevers and sore throat, and then watch your urine. If they have dark tea-colored urine, and it's usually a sign of, the hepatitis, drug-induced hepatitis, and I've had it twice where that's how the patients have known is the brown urine. Fatigue is way so non-specific, and I'll get called every other day. So that's not a very reliable one for a lot of my patients anyway. So we know that older people tend to respond really well to antithyroid drugs in general. People that have big goiters are less likely to have remission. People that have really severe abnormalities on the thyroid test also have less chance of remission. Smokers tend to not do as well. On antithyroid medications, patients that don't have goiters tend to have the best outcomes. So this is Graves' disease, no goiter, after 2 years of antithyroid drug therapy, and this is 106 months they're following with really low incidence of recurrence in people that have small thyroids versus the Graves patients with medium or large goiters, much higher. It's more than 40% that have recurrence. And then multinodular goiters, toxic nodules, the antithyroid drug really isn't a definitive therapy for that. If methimazole is chosen, the medication is usually continued for about 12 to 18 months, and we titrate down that dose to whatever is necessary. So I have a lot of people that are on 5 milligrams 3 times a week, or half a tablet 3 times a week, just the minimum that they need to maintain normal thyroid function. And then at the end of that time, it's advised that you repeat the thyroid receptor antibodies, the thyroid stimulating immunoglobulins, and monitor, assess are they still antibody positive or not. And the reason for that is it's predictive of their chance of remission. This is a typo on my part. It should say measurement of the antibodies, not management. But you measure the antibodies, and then this will help you know, can this patient be taken off therapy. So this is data from Thyroid 2006. In white are the patients that are in remission. In gray are the patients that have relapsed. And the antibody titers. So if the antibodies are less than 1, in this particular assay anyway, the antibodies are low, that the chance of remission is very good. If the antibodies are very high, they don't go into remission is the bottom line. They're still active disease and they need to be continue to be treated. So if a patient with Graves' disease becomes hyperthyroid after completing a course of methimazole, we usually will go back to the drawing board and present them with the options of definitive therapy with radioactive iodine or thyroidectomy, or another course of antithyroid drugs for another 12 or 18 months. We let the patients make this choice, again, assuming the patient's compliant with therapy and follow-up. When you look at the outcomes in Graves' disease patients with relapse, patients that were treated with methimazole for 12 to 24 months versus patients that were treated with radioactive iodine became hypothyroid and placed on thyroid hormone, and they were followed for 6 to 7 years. What they found was the patients with the methimazole, at this time point, 60 months later, 5 years later, there was a much higher chance of being euthyroid when you're on methimazole, and there were many more patients that were either hyperthyroid or hypothyroid after having radioactive iodine. The patients that had the radioactive iodine were also much heavier, about 5 kilos difference at the 5-year point, which for a lot of people is a lot of weight. And then when you look at the eye disease, there was a significantly higher incidence of worse Graves' eye disease in the patients that had the radioactive iodine versus the methimazole, and this shows the same thing. The iodine group had a significantly worsening number with significant worsening of eye disease. And it's thought that after the iodine, there's a rapid change in their thyroid levels, and that worsening and the changes in the thyroid function is what in part triggers the eye disease. So So my ophthalmology colleagues that treat a lot of eye disease are like, keep their levels normal, keep their levels normal. And if they're gonna have surgery, they want those levels perfectly normal for a long time before they'll even touch their eyes, because we know it correlates. And a lot of the patients will call me, my eyes are off, and they know their thyroid level's off because their eyes are off. It's a really good predictor. This is in conclusion that low-dose methimazole treatment can be a choice for long-term patients and patients with Graves' disease, especially when they have Graves' eye disease, or they really don't want to have ablative surgery, either radioactive iodine or surgery. So it is a choice to have somebody on anti-thyroid drug long-term. I may have pulled the slide out that shows, that is a choice over time, that the patients really do okay. This is just a little algorithm flow chart that after 12 or 24 months of anti-thyroid drugs, that you're going to check the antibodies again. If they're still positive, you'll continue therapy or move on to another choice of treatment. With respect to radioactive iodine, we use it. We certainly use it for thyroid cancer, and it's always an option for toxic nodules and for Graves' disease. There's no evidence that it leads to infertility or birth defects later. We never give it to somebody that's pregnant. Absolutely contraindicated in pregnancy because you don't want to destroy the baby's thyroid. It may worsen pre-existing Graves' eye disease, and it may even induce eye disease in patients that have baseline normal eyes. And we know that there's a transient worsening of thyroid function after radioactive iodine in about 1% of patients. And then there's some subtle data that suggests that thyroid cancer actually may be more frequent in patients that have toxic multinodular goiters that are treated with radioactive iodine. It is not good for the eyes, as I said. The more severe the hyperthyroidism, the worse effect for iodine treatment and worsening the eye disease. People that have really high thyroid stimulating antibody titers tend to have a higher risk for Graves' eye disease. It's the thought that the same antibody, the thyroid stimulating antibody that drives the thyroid, also causes the changes in the eye muscle. It makes that muscle act like a sponge and hang on to water, and that's what causes this bulging. And those antibodies are what we think is in large part driving the thyroid eye disease. You can give steroids to patients that have Graves' eye disease if you're going to treat them with radioactive iodine, and it's usually 4 to 6 weeks of pretty high dose prednisone. Sometimes they're given it as an IV dose once a week, and there's some recent data that shows even a little lower doses than what's typically been used may be effective. But prednisone's bad. I mean, it gives you lots of problems with blood pressure and cataracts, glaucoma. It's bad for the bones. And bad for metabolic effects, the weight. Endocrinologists really don't like steroids in people that don't need steroids. So I usually will go to surgery or anti-thyroid drugs before iodine in most patients that have eye disease. So back to our guy. He comes in, as I said, back in January 15 with this new diagnosis of Graves' disease. He gets put on PTU. He sees me in February, and I flip him already to methimazole. And I flipped him because his free T4, one, I wanted him on methimazole because it's once a day for compliance, less hepatotoxic. But I went kind of low on the dose at 5 because his free T4 was already almost normal after just a few weeks. So anti-thyroid drugs can work really fast, and it doesn't mean you have to give him a whopping high dose of 40 or 60 milligrams a day. Even lower doses, they will respond. So he goes on 5 milligrams a day, and then the next free T4 is a little higher, so I scooted him back up to 10 milligrams a day. He looked okay, and then his TSH by June, so just a few months on medicine, is starting to recover. I'm measuring the TSH, but the free T4 is disproportionately low, and this is what happens. The free T4 has got to come down, and that's what's going to wake up the brain to start making TSH again. So you can't just look at the TSH, you got to look at both until that pituitary function recovers. So now, by July, his TSH is up to 4.8, which is not good for his eyes, and I'm pulling the methimazole back. And then he stayed normal, and then after a couple of years of therapy, January 17, his TSH is normal, his thyroid stimulant immunoglobulins are now normal, and I've taken him off methimazole. So since the spring of I guess it was 16, he's been off antithyroid, is that right? Off therapy, August of 17. I stopped it here, January 17. And he's been off for almost 2 full years, and he's been good. He went to the Eye Institute, he went through the procedure of having these infusions. He did incredibly well. His eyes have got full recovery. He still is a little ejected. He has no proptosis. He can see out of both eyes. In the middle of all this Graves' eye disease and his due diagnosis, he and his wife went to Greece, and he managed, because of his depth perception and not seeing well, fall down a whole bunch of stairs, ended up in the hospital in Greece, and fractures, and it was a total mess. He has bad bones, and he's refusing to treat his osteoporosis. But he has been accepting of his antithyroid drug therapy, and he's been euthyroid. So the eyes have been a good outcome, and his thyroid's been a good outcome. So subclinical hypothyroidism, I'm going to shift gears a little bit here on you. This is, again, the biochemical abnormality of the elevated TSH with a normal free T4, irrespective of symptoms. And there is a differential diagnosis for subclinical thyroid disease. The recovery phase of non-thyroid illness can do that. After thyroiditis, that, as the thyroid is recovering, the TSH can be mildly elevated. You can get antibodies that interfere with the TSH assay, including rheumatoid factors. Adrenal insufficiency patients will have these mild elevations in TSH, these rare TSH-producing pituitary tumors, central hypothyroidism. So there are other things you have to think about besides just the thyroid's not making enough hormone. We worry mostly because some of these patients will go on to get overt hypothyroidism. There's an association with a higher risk for cardiovascular disease when the TSH is over 10, higher risk for heart failure, higher risk for stroke in younger patients, lipid abnormalities with higher LDL and total cholesterol. There's clearly an association with reproductive abnormalities, higher risk of miscarriage in women with subclinical hypothyroidism, and even those that are euthyroid with positive TPO antibodies. There's also an association with non-alcoholic fatty liver disease and neuropsych symptoms. The problem is we don't have data to show that if you fix it, you lower all that risk. We have associations that they're linked to these things, but no proof that treatment fixes these things. Currently, all the professional groups advise therapy if the TSH is over 10, and we will treat patients sometimes that have an upper limit of normal TSH up to 10, but it's really controversial. And the biggest reason for that is the lack of demonstrated benefit in short-term randomized placebo-controlled trials. In patients that have subclinical hypothyroidism and a goiter, the treatment may make the goiter smaller, so that might be a reason to justify therapy in that group of patients. But you wouldn't just write for thyroid hormone in patients that have hypothyroid symptoms, especially when they have a normal thyroid function test biochemically. There's a lot of patients that are tired, their hair is falling out, they're constipated, their mood isn't good, and they're not all hypothyroid, and that's our big problem. And they have all been on the internet, and they all have friends, and they all think that thyroid hormone is the answer. There have been 2 large meta-analyses of all the trials looking at patients with subclinical thyroid disease, and the conclusion is that it does not make any significant improvement in their symptoms, quality of life, depression, or cognition. So this paper was just published in JAMA. You may have seen it last month. Randomized, it's a meta-analyses of all the trials looking at thyroid hormone replacement in subclinical disease with really no significant benefit in quality of life, thyroid-related symptoms, fatigue, and depression. And for those of you in practice that have given thyroid hormone to people, they come back and they feel fabulous, and their TSH is 3 or whatever it is, and they feel fabulous. And about 6 weeks after that, or 2 months, they're complaining again that they're tired, right? They're gaining weight, and it really hasn't made any difference. And I think those of us that treat patients know it doesn't stick. It's a placebo effect, I think, is what we're treating and making them happy. And then this is the cognitive function, no improvement with thyroid hormone. If it's overt hypothyroidism, the goal is to make them feel better, fix the symptoms, normalize the TSH, reduce the size of the goiter, not overtreat them, and try to get a TSH within normal range. Most of us use standard levothyroxine. It's a tablet. It's colored, so every dose and every company, whether it's Synthroid, Levoxyl, or whatever generic, they all follow the same color chart. 50s are always white, yellows are always 100. You can look at the color, you know what dose they're getting. It's very rare to have a diallergy, but you can get around that with the right combination of pills. There's a product called Tirosint. It's a gelatin capsule with this levothyroxine. It's really expensive. I think it's about $170 a month if you get paid for it, and rarely does insurance cover, but some people swear they feel better with it. The bioequivalence study was done about 20 years ago where they looked at Levoxyl, Synthroid, and 2 generics. Didn't show any difference, so for those of you in practice longer, remember the days when we wrote Synthroid and they couldn't switch it, and now most people get generic no matter what we do, and they pay dearly. It's about $1 a pill to get rid of Synthroid now. If you have a patient that's had a thyroidectomy, you have to pick a dose. We start with about 1.6 micrograms per kilogram per day. That calculation works really well for ideal body weight. If somebody's very obese, it doesn't hold very well. We have to kind of do a fudge factor to guess what they need. If somebody's old, we usually start with 25 micrograms a day. If they have heart disease, we'll start gently and nudge them up. We make sure that they're taking it properly, which means in the morning, empty stomach, without PPIs, without calcium, without iron, without vitamins, without other things that are going to bind up the thyroid hormone. There is some data that they can take it at bedtime, and if there's a few hours between dinner and bedtime, some people do better with that regimen. Coffee can affect it. The Italians did a study with just plain black coffee, and it was like 40% absorption versus when the coffee wasn't there. So the coffee, black coffee isn't good. It takes about 6 weeks to get steady state. So we're usually checking the TSH about 6 weeks after starting a dose or changing a dose. What about combination therapy? Both T4 and T3 are produced in the thyroid gland. T3, about 15% comes directly from the thyroid, and the 85% is converted from T4 in the bloodstream by an enzyme deiodinase. It's really regulated by our body, so if you give levothyroxine, it doesn't mean somebody's T3 deficient. They're going to convert some of that T4 to T3 as they need it, so they're not out of T3 most of the time. We all have patients that are hypothyroid. Their TSH is perfect, but they still complain. They're still symptomatic despite these optimal levels, and that may be 9 to 13% more commonly than patients that don't have thyroid disease that have normal TSH. And there's a thought that some of these people really do have a problem with that deiodinase, that they don't convert to T3. There are trials looking at combination of T4 and T3, but most of them have used non-physiologic doses of T3, and really only one has showed a significant improvement in neurocognitive effects. It was maybe 20 years ago, I think, when that study was done and T3 got really popular again. But the whole idea, if you're going to use combination, is to mimic normal human physiology. So we're about 13 to 1, 16 to 1, T4 to T3. Armor thyroid or desiccated thyroid extract is about 4 to 1. It's very high in T3. And T3 has a short half-life compared to T4. Levothyroxine, you take it today, half of it's in you a week from now from that first dose. T3, you're more up and down. T3, it only comes in 5 and 25 microgram tablets. It's about 3 to 4 more times more potent than T4, microgram per microgram. So 5 of T3 is like 15 to 20 of T4. If you put people on both, you got to monitor both the TSH and the free T4, but there's not much value in measuring the T3 because it moves. If you measure them 2 hours after they take it, it'll look really different than if you measure it tomorrow morning when they haven't had it for 24 hours. And that's what the naturopaths do. I hope there's no naturopaths in here that I'm offending, but the people that do a lot of armored thyroid give these people these whopping doses. They tell them that the TSH doesn't matter, and they tell them to hold it for 24 hours before they even measure the T3 again, and they all come low. The T4 looks low and T3 is low, and that justifies a bigger dose until they come in here with AFib and A-flutter and God knows what else. But if you're going to do it, gently, and you want to be careful with who you're picking. Just as an example, patient that is doing well with levothyroxine 175 but complaining, I would cut that T4 dose back, and in this example I picked 137 and added 5 micrograms of T3 twice a day, so the ratio is 13.7 parts T4 to 1. Human physiology, and then we repeat the levels about 6 weeks later. If you're going to do levothyroxine, pick a younger person. It's usually people that have had thyroidectomies or that have had radioactive iodine and they just don't feel well since their thyroid came out, or somebody that really does have a low T3 that you're going to think about treating. Be really careful with your older patients. Be really careful with patients that have cardiovascular disease because of the variability of the T3 level. And do not give it to women that are pregnant. The fetal neurogenesis is dependent on normal maternal free T4 concentrations, and the T3 takes that down. So it's not a drug for pregnancy. Do I have time? I'll just make a couple points. That in physiology and pregnancy, TSH goes down. There's a lot of homology between the TSH molecule and the alpha subunit of beta HCG. So normal physiology early in pregnancy is that the TSH decreases. So a normal TSH in first trimester pregnancy can be as low as 0.1. Moms that are pregnant need more thyroid hormone, and we usually, as soon as we recognize that they're pregnant, we will up their dose by 2 pills per week. And moms that are thinking about pregnancy, we will treat based on the pregnancy guidelines. If we don't have this here, but if we don't have a TSH standard for pregnancy, we'll use a TSH upper normal of 4. So anybody over 4 that's contemplating pregnancy will treat to normalize that. And that's mostly because all the data with miscarriage and bad effects on the pregnancy. Thyroid antibodies, even in new thyroid women, I said were associated with adverse pregnancy outcomes and miscarriage. And so we will usually treat those women that we know are antibody positive, especially if their TSH is higher. We usually aim for a TSH less than 2.5, especially if they've had a prior history of miscarriage. And then we monitor them. And if they're not on treatment, they get TSHs every 4 weeks because a good number of those will progress. I'm sorry this talk is long. I'm being here for a few minutes if you have questions. And thank you for your attention.